Hello, future RNs. Because I'm doing this during the day, we run the risk of my kids interrupting. I apologize now for any chaos in the background. However, with all the exams that you have coming up in the next week, I wanted to get this out to you sooner rather than later. So today I'm doing a quick refresher on what we talked about in lecture on schizophrenia and the schizophrenia spectrum disorders. So, all of these have psychosis, right? A detachment from reality, cognition, perception difficulties. You don't know what's real or not real. With these four, we'll go over them on the next few slides. Don't delve too deep into them, right? What is the difference? Because a lot of them are going to share characteristics of schizophrenia. So delusional disorder is having a delusion and 1 month or longer. Not necessarily like schizophrenia, you might have a delusion and hallucinations. Delusions are just right purgatory. The CIA is out to get me. Grandiose, I really invented Tesla. Elon Musk stole the thoughts from my head. I should have all of the money, not him. And they don't usually impair daily functioning, right? This is going to be the person who has the tinfoil hat and the tinfoil on the windows, but that's it. Went too fast. Brief psychotic disorder has the delusions, has the hallucinations, has speech changes and odd behaviors, but they last less than a month. The patient could return to normal and have a normal level of functioning once this is done. So brief psychotic disorder lasts a day to a month. Schizophreniform is just like schizophrenia, but it is less than 6 months. You see the social impairment as well as hallucinations. And we kind of don't know. Some individuals do well and go back to normal, and others have some difficulty, but it's not full-blown schizophrenia. It's 1 month to 6 months. Schizoaffective disorder is someone who has schizophrenia, but also has depression, or also has mania, or has both. And usually we would see it labeled like schizoaffective depressive type, schizoaffective mania type, or schizoaffective mixed. And they have the criteria for both because they also meet the criteria for schizophrenia. So of those three, the other ones we talked about, the brief psychotic disorder is less than a month. Schizophreniform is 1 to 6 months. And schizophrenia has to have those symptoms for 6 months. So what is schizophrenia? We tend to see this start in men 15 to 25 and women 25 to 35. And it has a lot of comorbidities we see with substance use and depression. Suicide is a huge risk with schizophrenia, as well as physical illness. There are some risk factors, right? And one of the questions some of y'all asked in class was, how do you tell the difference? Well, genetics plays a huge role. If a patient comes in and they have their first psychotic break, and this is new, we might ask, is there a family history of schizophrenia? Because if there is, we're going to lean to schizophrenia versus something else. You also tend to see an increase in dopamine. Prenatal stressors, right? Flu. That is why winter, spring birth, because the chances of mother having influenza at that point in time in the pregnancy, and a father older than 35 increases risk of schizophrenia. Psychological stressors, often you see schizophrenia in a stressful time. You know, that 15 to 25, 15 to 35, that's just a stressful time period for every group. You also can see environmental stressors such as toxins. I know y'all are going to say, is meth really an environmental toxin? But when you put meth in your body, you run the risk of having schizophrenia. There's even studies that link marijuana usage to an increased risk of schizophrenia. So most cases don't fully respond to treatment, and it's really hard. You have worse outcomes if there's a longer time period between that first symptom and when we can start treatment, or if it's a slower onset, or if you're younger when it starts. If you have a good support system, if you have higher education, those are linked towards more positive outcomes. So phases of schizophrenia. Don't get too crazy about this, okay? Prodromal is when you start to see a lot of those negative symptoms. Just a general decline in functioning. But you don't meet the criteria for schizophrenia. There might be odd speech, there might be anxiety, your school and work function isn't doing as well. Kind of just feel like something strange is happening. The acute phase or the active phase, that is that psychotic break where there's the delusions, there's the hallucinations, there's the strange speech. And while that lead up, that prodromal phase could last days to months, the acute phase generally lasts at least a month, at least a month. And that's like where we tend to see patients hospitalized. The residual phase, maintenance phase, stabilization, link it all together. Don't freak out about this, y'all. We see the hallucinations and the positive symptoms disappear, but those negative symptoms and the emotional symptoms tend to stay. And that can last for weeks to decades. And the patient will kind of go back and forth between that active phase and the residual phase. And that active phase to residual phase kind of makes like a looping circle. So all these symptoms that we're talking about, what are they? Positive symptoms. Those are the things where you're like, is this real or is this not real? Right? The delusions, CIA out to get you. The birds outside my window are really drones who are sent to spy on me. The Russians have kidnapped my baby. Alterations in speech. Things we hear that are different. So word salad, right? Some of the ones we talked about in class today where there's random words coming out of the patient's mouth and you're like, I don't know what this sentence means, but you know what the words mean, right? Boot, pen, green, flower, monkey, hat. We all know what those words mean by themselves, but when you put them in the sentence, it doesn't make any sense. Word salad. Neologisms are made-up words that mean something to the patient. But to the rest of us, we don't know what it means. And sometimes where I see this more in some patients is if they're talking in tongues. Slang associations, everything rhymes, right? So those positive symptoms are the things we're adding on to a normal human being and the things that we can see where it's like, or hear or listen to, where we're like, hey, there's something up with this patient. We can do all of these as objective data. The negative symptoms are the things we take away, right? Anhedonia, lack of pleasure. Avolition, loss of motivation, right? Goal-directed behavior, there is none. You can't get going. You can't be self-starting. Asociality, decreased desire, or uncomfortability with social interaction. Affective blunting, our facial expression does not change. Apathy, things that used to give you pleasure no longer do. Analogia, no speech. None at all. Right? So where the positive symptoms, we have those strange speech. And that strange speech is a positive symptom. Alogia, the lack of speech, is a negative symptom because we're taking away your speech. So what do? We have to look at all sorts of things with our patients, right? They're very resistant to treatment because they don't like medications, right? They tend to cheek meds. Depression and suicide is a huge risk, right? Fall risk. If the patient does not have a good attachment to reality, we have to be cautious because are they going to fall? Restlessness, agitation, right? And priorities are almost always going to be risk for other directed violence or self-directed violence. So in the hallucinating patient, we have to watch for signs that they're hallucinating. Are they talking to themselves? Are they like staring up in a corner? We have to ask about the hallucinations. What is it? Are they telling you to do anything? Watch for anxiety, empathy. I don't hear those voices, but it must be scary. And we have to try to keep them in the here and now. Stress and stimulation can increase hallucinations and increase the difficulties in these patients. So we have to teach them to decrease it. Get them engaged in activity. Get them talking. set up a support system, and set up a general plan on how they can cope. The delusional patient, we have to build trust, stay matter of fact. We cannot debate the delusions. If something is real, we do have to validate it. There are birds outside the window, but we can't feed into the part or tell them, no, the birds aren't drones. Acknowledge that the delusion seems real to the patient. It is not real to others. We have to focus on reality. All sorts of patient and family teaching, right? They need to keep up with the support system, go to support groups. Diet, exercise, sleep, self-reduction, self-care are all super important, and that carries over for any of these diagnoses we're talking about. Medications, they are not going anywhere, y'all, right? So first generation affects dopamine more so, and these are our older. Our thorazine and our haldol are the two common ones. And first generation, you tend to see the repetitive movements more, that extrapyramidal symptom type side effects, because of the effect on dopamine. We see the sedation and the prolactin and some other stuff too. But those EPS, that tardive dyskinesia, are some of the ones that are most scary to patients. And we have to make sure with those first generation, those dopamine induced movement, that we're educating on them, right? So pseudo-Parkinsonism, they're shuffled over, they're rigid, they're shaken, and they got that fingers like they're rolling a pill between their hand. This is like the thorazine shuffle. Acute dystonia, the eyes are fixed on the ceiling, an ocular gyrate crisis, and the muscles have just contracted and spasmed and they can't uncontract them. Akathisia, restless, cannot sit still. No matter what you do, a patient with akathisia is just going to be pacing. Their feet will be in constant motion. Just give them a hallway and let them walk. Tardive dyskinesia is the one that's permanent. Once this happens, we can try to keep it from getting worse, and we can give the medications to help keep it from getting worse, but it might not ever get better. And that's the tongue sticking out, sucking, smacking, chewing motions. If you see a lot of it of the face, it can involve the extremities too. So from this slide, we've already talked about some of this EPS treatment, Cogentin and Benadryl. Right, Cogentin's one of your Parkinson's meds, and we give that to help kind of even out that dopamine. Second generation antipsychotics, they affect dopamine and serotonin. So while the first generation affects just the dopamine, they work more with hallucinations. The dopamine and serotonin work equally well with both the positive and negative symptoms. They're less likely to cause those repetitive movement side effects. So second generation is not as likely to cause tardive dyskinesia or EPS. The side effects are usually mild, but they stick in that metabolic syndrome. The weight gain, increased lipids, glucose, insulin resistance, we see that metabolic syndrome more so than the repetitive movements. Clozapine or Clozaril is one of the most effective second generation antipsychotics we have. However, it has a high risk of agranulocytosis, lack of white blood cells. So with these patients, we need to monitor. We need to be checking their blood counts. We need to be educating them. Hey, if you get sick, call us. Let us come on in. We'll order some labs. We'll check your white blood cell count. Because this is someone where if they present with a sore throat and, 100.6 degree temperature, well, usually we're like, meh, probably nothing. If they have agranulocytosis, if they're neutropenic, we need to go check that out. Third generation antipsychotics are a subset of the second generation. It includes Abilify. I wouldn't worry too much, except, it exists. Abilify you see used more so in kids a lot. It's used in everyone, but we give it a lot to kids because of the less side effects. So the dangerous side effects, I say the other, we've talked about some of these, of antipsychotics that we need to think about. Anticholinergic side effects, right? And it can cause anticholinergic toxicity, which honestly, anticholinergic toxicity kind of looks sometimes like neuroleptic malignant syndrome. And neuroleptic malignant syndrome, that is that super high fever. All of a sudden, your patient has a 105-degree temperature, they're confused, they have muscle rigidity, their heart rate's high, their respiratory rate's high, right? I'm a psych nurse, I don't do the medical stuff, I call 911 because we can't do anything for them. I can give you a cool towel, I can give you some cold water, but that's not going to work for neuroleptic malignant syndrome. Agranulocytosis, right? You're more susceptible to different types of infections. So we have to monitor our white blood cell count, our neutrophils in those patients. Prolonged QT interval, we're just going to check the patient. It's always best practice if you're going to start a new antipsychotic to get an EKG. Does it always happen? Nope. But get a baseline before you start it. And then liver impairment. We can see liver impairment with all of these just because of how they affect the liver. So that is it for psychosis. Thankfully, I hear my kids coming now, so my timing is perfect. If y'all have any questions, please reach out.